But the crisis is going on in the other direction as well. I think it's fair to say every one of our health system clients has asked a question, or is in fact actively pursuing, in some shape or fashion, moving into the insurance business. Should I have my own products on the exchanges? Should I get an insurance license if I'm in a state that requires that? Should I white label my own products? All of these questions are actually blurring the distinction between what it means to be an insurer and what it means to be a provider organization. Leap of faith. It's an interesting term here as we think through this. If you look at the models we're all moving to, we're trying to move from volume to value, ACOs, various forms of gain sharing, capitations coming back in different ways, bundled payments. If you then look at the literature and the evidence and the economic studies, the track record, the financial evidence, the viability are at best limited. And so we see a lot of organizations who are essentially sort of taking a leap of faith. The economic models may not be proven out, but they know they have to move here. And so there's a lot of this activity that's going on without any real confidence or certainty that where organizations will go will necessarily be a safe place. And the last one I think all of you heard is this question we hear, which is, what makes this different this time around? Any of us who've been in healthcare a long time, it feels a lot like Back to the Future, right? We have new names for old terms, capitation, ACOs sound like pieces and elements of managed care of the past. So what makes it different? And I think some of the things we're seeing here on this front is that perhaps we are in a different place with technology than we were in the previous time. And we would argue that we are in a different place in terms of where the crisis or the affordability challenges sits in our country. And if we look at the total spend, whether we have government health care or not, we certainly will increasingly have government-funded health care. Right? Our projections suggest that over the next decade, the government, either through Medicare, Medicaid, or through subsidies on exchanges, could be as much as 2/3 of the total dollars spent. So those are some of the things that we believe make the environment this time around very different than what we saw in the 90s and 2000s as well. So this is just a bit of data that for many of you probably is not unfamiliar, but it's simply to say that no one is immune. So if you look on this list here, for example, on the left, Boston Children's, I think #2 ranked children's hospital in the country. Right? You would think has a preeminent position, cannot be excluded from any payer's network, should be able to ride this storm out. Not true. Eliminating jobs has to take out $150 million in costs this year, was actually tiered out of a network by an insurer, and actually had to ask to be put back in the network and had to make a number of concessions. A couple blocks away from here, Northwestern Memorial Hospital, another 200 jobs eliminated. They're looking at cutting costs by 25% by 2017. So this is just to say that the cost picture, the affordability challenge is very real, and we're starting to see it manifest itself across the country, from academic systems, community hospitals. There's no one who's immune from the trend that we're seeing here. Some analysis we've done as a firm. This is national analysis, and it's done in an aggregated fashion, so it's not to say every health system or every market will look this way. But it is our perspective on what we believe will happen to reimbursement yield over the next decade. And if you look at the different piece parts here, what happens with changing reimbursement mix, what happens with state budget deficits, and finally commercial pricing pressure, you can see that various pieces of the puzzle contribute to ultimately what is a picture where reimbursement yields by 2020 could be as low as, or could be lower by as much as 30%. I think fair to say on the right here, where you see commercial pricing pressure, that's where there's significant uncertainty. I think the main driver behind this is how health insurance exchanges play out. I think when I was in an AHA meeting a number of years ago, and health insurance exchanges were out, and everyone was asked the question, what kind of reimbursement do hospitals and physicians think they will get as part of being on exchanges? And the answer was, well, maybe not fully commercial, but certainly greater than Medicare. And the question was asked the following year, and I think most people in the room said, well, we think it's probably going to be Medicare reimbursement. I think what we're seeing and hearing from clients now is that if you're in a strong position on the exchange environment, you will see something that's sort of slightly greater than Medicare. But if you are in a more difficult environment, some insurers are looking at something between Medicaid and Medicare at the reimbursement rate. That uncertainty drives the major component of uncertainty in terms of our projections around these numbers. Just to make this real for a second, this is work we did with a community hospital in the Northwest, or in the Midwest, I should say. And you can see that on the positive side, there are a number of factors that drive increases in margin. Right? So the demographics, some of the increases in utilization that are expected, some of the value that then is declined because of readmissions and the like. But you see the major changes that occur really are in the payment structure. Movement to exchanges, what happens with Medicare and Medicaid rate, and even with a one-time commercial rate adjustment, the projections for this institution was that their margins would be -7% from where they are today. So, a very real example of all the various pressures coming together and what they mean for the environment. It's fair to say that reimbursement payment pressure is not only going to come from what's happening with the government, it's actually going to come from consumers. As many of you saw, it's hard to miss. CMS released the data this week, right? The data that allows consumers or at least certainly many of the leading newspapers across the country made it the front page story. Looking at both payment and charge data for common procedures and conditions that are available. We see that trend growing for a number of reasons. Firstly, as high deductible health plan products have taken hold, the kind of shopping behavior that's underway is likely to increase, particularly in the outpatient service environment. The second piece of this is if you look at what's happening on the right-hand side, the size of the individual market. The individual market, as a result of health insurance reform, will grow by almost 41% over the next several years. So as individuals take more control over their healthcare spend, particularly on the outpatient side where it is difficult to demonstrate the value and quality for a premium price, the pricing pressure that will be created by the consumer component will also put downward pressure on hospitals and health systems across the country. I want to share a little bit of research that we've done around this notion of hospital-branded products on exchanges. It's a big topic that a lot of health systems have entertained, whether or not they should be on an exchange and whether they should be on the exchange branded as themselves. And what's interesting is, as we've done this research, and these are by the different segments of consumers, that not surprisingly in many markets, the blue plan is still the place where that has the most loyalty. So most people are still likely to choose the Blue Cross or Blue Shield plan that exists in their market. But what's interesting is and the other gray bar is not labeled, are actually other major national plans. What's interesting is a very close second, and in some cases, and particularly in the currently uninsured market, there's a strong preference for a hospital-branded plan. And we tested this in major metropolitan markets, and we tested it with brand name facilities as well as some of the major health systems that exist in the suburban and exurban areas as well. So it says there is an opportunity here as you think about potentially participation directly in the exchange environment or perhaps through white label type arrangements. So what are the things that folks are doing in response to a very difficult economic set of pressures that are being created on health, that health systems are seeing? I think on the left-hand side, many of these things will be familiar to you. The kinds of what we've called sort of incremental optimization. So every one of our hospitals and health system clients is engaged in a cost reduction effort of some sort. Big or small, even the ones that are doing very well are reducing their costs. Questions about service line portfolio rebalancing. What should and shouldn't I be in? What lines of businesses make sense to me? Everyone's marketing. Branding's becoming big, particularly as people are trying to establish themselves as important or must-have facilities in the networks as narrow and tiered network products continue to take hold on the insurance side. A lot of renegotiating with health plans, lots of payment model experiments, and then certainly opportunistic mergers and acquisitions. And most of this, at least as we heard from the prior speaker, has started to take hold in the form of selective acquisition of physician practices. In the middle, you'll see that there are some organizations that have started down the path of really trying to ask the question, how do we right-size ourselves and expand? So here, the merger and acquisition activity is really about how do we build out the network and the scale that we need, and how do we start to think about not just the sort of traditional inpatient and hospital outpatient component, but truly how do we integrate care across the continuum. Naturally, much of this has started in the post-acute care side, where risk for readmissions and the like have caused many institutions to think about what that integration looks like. But we're also seeing it occur sort of in the pre-component as well, whether it relates to retail clinics and other elements that may in fact be entry points into an overall health systems network. And then we are seeing some very, I'd say, advanced organizations, ones that have already been down the journey of the first two boxes, start to really think about transforming themselves. That is to say, how do we innovate on our care model altogether? So this is not simply taking lean and trying to take my current process and make it more efficient, but fundamentally rethinking how does the process work and how do I need to restructure that process in a new world environment. What are the kinds of business model innovations I might take? Do I need to change my operating model? And we'll get into some kinds of operating models we're seeing. And finally, doing mergers and acquisitions not simply for traditional reasons of trying to get bigger for the purposes of leverage or opportunistically trying to bring physicians into the fold, but more importantly thinking about what are the capabilities in a value-driven environment that I need to have, what's the footprint and what are the assets, and using that lens as a vehicle for how they think about M&A. Talk about what we see this all meaning for health system strategy. If you think about sort of traditionally the way a hospital and a health system has thought about strategy, and if you think about strategy as really, one is the function, that is to say, what is it you do, and then the form, that is to say, what is the structure that you have that enables you to deliver on that function. Hospitals and health systems have had a much narrower view on how they think about that. So let me just give you an example. If you think about a traditional retailer, right, their function will be about really what are the mix of products and services that I sell to my to consumers, what's the value proposition I offer, and then what are the assets I need to be able to do that. So that might be real estate, it might be inventory that I need, but then it's not just the asset, the physical assets, but they also think about what are the kinds of capabilities that I need to be able to deliver on that. So design skills, merchandising, all those elements become very important. Now let's think back about sort of how classically health systems have thought about their strategy. Okay. Most of them think about it, and we found it as we go through this with organizations, predominantly nonprofit, but certainly even for-profit, they start to think about it first through the lens of mission. Right? Am I a safety net hospital? Am I an academic medical center? Am I a community hospital? Right? And then once they've thought about their function more as the mission, then they've thought about, okay, what's the form? And form has always been about assets. Do I need to have more ambulatory surgical centers or fewer ambulatory surgical centers? How far to outpatient should I be? What service line should I be in? And it's been less about what are the capabilities that I need. So if you look on the left here, most of what strategy's been, it's been about, as I've said, the mission. The value proposition, so the message we send to consumers, to customers, to payers, to employers, has really been a lot about we're all things to all people. Competition's been really about volume, it's been about brand, perhaps it's been about having the state-of-the-art care, research. The focus has been about illness, It's been predominantly hospital-based in nature, though there's been some evolution in that thinking. And if you think about the kinds of capabilities you needed in the traditional world, it's can I affiliate with my physicians? How do I get access to capital so I can build out the infrastructure that I need to be able to support that, to purchase the equipment that I need, revenue cycle, and how do I run operations? And quality, interestingly enough, and process excellence have actually been differentiated. If you look on the right-hand side, where do we see the market going? So firstly, from a strategy perspective, we actually see organizations becoming a lot more prospective in how they think about strategy and really thinking about who are the customers that they are targeting and then demonstrating the discipline around the investment that they make so that they align with those customer targets and segments. Related to that, it's not all things to all people anymore. It is truly, what is the point of differentiation that I have with the customers that I serve, whether they are consumers, public payers, or private payers? And we'll talk a little bit more about what we mean by value propositions. The way you win won't be on volume, it won't be on pricing power, it will really be about value. Right? And we'll talk, and value, I know it is a difficult word, and value will take different meanings in different settings. It won't be just illness, but also elements of wellness, and increasingly retail, mobile, home health, things that have the health industry in the aggregate has lagged will become part of what you as health systems will need to think about beyond sort of traditional hospital-based operations. And then when you think about this point about capabilities, it's no longer about some of the functions that are performed, but it's about a new set of capabilities. So how do I manage data and analytics? So informatics, clinical and business intelligence are absolutely critical in the future environment. How do I think about continually redesigning my care processes, population and risk management, and patient experience? Right? All of these elements become very important new capabilities that heretofore have not been the central focus of where health systems have really invested or thought about as critical to being able to deliver on their strategy. And then the last point I would say is that quality and really the ability to have process excellence will no longer be something you can differentiate yourself upon. It'll actually be table stakes. And it's not going to happen overnight, but if you look at where consumers are pushing, where CMS is pushing, there's going to be a certain minimum level that everyone expects, and that's going to be given in the new environment. Won't spend a lot of time on this slide just in the interest of time here, but this talks a little bit about the kinds of changes that different types of institutions will need to start to think about. So community hospitals, they'll need to start thinking about really, do I have a right to do this? Right? So in my market, am I the best entity or institution to be able to deliver on this? Because if I'm not, then I may not be the right organization to be delivering on that in the future. Academic medical centers, right? And we all know that for good reasons, academic medical centers have a higher cost structure. Right? They have an educational mission, a research and a teaching mission. Right? But how now in the future where price, affordability, those elements become very critical, how do you justify the fact that there is a premium price associated with the services they deliver? And will there in fact need to be a rethinking where some things that are currently rendered in an academic medical center today need to be rendered in a different setting? And how then do they replace the volume and services that used to occur heretofore in those settings and could arguably be pushed out to lower acuity environments with new volume and services? And then finally, if you're a multi-hospital health system, what's the operating model that you need? How do you actually put together or stitch the assets that you have in a way where you create an operating model that allows you to take advantage of the scale, right, to be innovative, and really have what we'll call systemness? And I think most everyone can cite an example of a merger that's occurred or a health system that's occurred that is at best a system in name only. Right? These organizations will be absolutely critical that they begin to really extract the value that comes from being a system in a way that heretofore many such organizations have not yet done or have not yet invested in doing. So let's talk about at least some of the consumer value propositions we are starting to see emerge. And let me start on the right-hand side here with 7. You think about access, right, and really pushing on the question of sort of how do we configure our footprint. There's really 2 kinds of plays we're seeing emerge in the market. There are organizations who will take what we'll call the convenience king play. Right? And this is essentially an organization that has all of the relevant services in a market, right, where in sort of a one-stop shop sort of effort, a consumer can go and get care. In contrast, you take an integrator who may not have all of it under their own roof, but really their role is about connecting the dots. So they're solving the problem of fragmentation, and they're serving as the connective tissue or glue that brings together the disparate components so that ultimately what their patients experience, even if not all owned by the system, is a degree of integration and a degree of coordination that results in high patient satisfaction. In the care dimension, we see two what we'll call pure tone strategies emerging. There are some players who are clearly trying to be the innovator. Right? This is, we will be cutting edge in everything we do. We will be innovative not just from a technology perspective, not just from a care perspective, but we will be innovative in terms of how we go about delivering patient care. So you might think, for example, Cleveland Clinic as the kind of organization that would sit here. These are organizations that naturally would see their draw as not just their local market, not just the nation, but arguably international as well. Then have a similar but different group called specialists. And these you might view as more center of excellence type facilities. Not to say they don't have elements of innovation, but really how they're going to differentiate themselves in the marketplace is by expertise and the end-to-end set of capabilities you need around a particular disease condition or condition area. So certain cancer centers might qualify here. MD Anderson as an example. Not to say it's not innovative in nature, but by our definition would sit in the specialist box. On the cost side, so we see 3 kinds of players. Some that are really viewing themselves as what we'll call premium properties. These are basically targeted at those individuals who want the best of everything. They want the private floors, they want the privacy, they want the ability to have a very exclusive set of services. It's probably questions about how large this market is, but many of you might see this as the floor or wing of a hospital that's dedicated for high-end type of clients. There's the price cutter. Think of this as the Walmart of healthcare. And this is, we are lowest cost. Right? We're still quality, but we are absolutely lowest cost. Right? And maybe this doesn't hold for all services, but if you think about many of the services you render, particularly on the outpatient side, there's arguably a commodity nature to them that makes it very difficult to differentiate. And so it's likely to see that there will be providers who adopt a positioning that really is, I'm the most affordable place to go get care. The contrast to that might be someone we call the value maximizer. This is the right price given the set of value that I deliver. So for a certain set of outcomes, right, I'm priced in a reasonable fashion. And so a good example of an organization that's really adopted the value maximizer play might be Steward Healthcare in Massachusetts, what they're trying to do. Think of them in the retail environment, that might be Target. So Target is not, it's not as low cost as Walmart, but for the value that you get for the products, right, Target has positioned itself in that particular environment.
That's a good question.
Yep.
Are those 3 discrete categories, or is there some overlap based on either what region you work on, if you're a multi-specialty, if you're a multi-hospital system that covers a lot of different regions? I'm just curious, based on specialties that you focus on.
Yeah, so actually it's a great question, and to my next slide, what we find is that these pure tones don't actually exist in nature, right? In the sense that no one's really just one of these, right? And in fact, there are logical combinations of these that make sense. right? And so for us, we would say hybrids, right? So you could actually have multiple strategies or models, but they have to be logical in nature. So one of the things we find, for example, that's very difficult, it's very hard to be both premium and also the cost cutter at the same time. Right? And some organizations, interestingly enough, are trying, and it is very, very hard for them culturally. In contrast, is being an academic medical center who's an innovator and premium consistent? Absolutely. And so you see that it's not so much about I need to be one and only one, but it's as I think about what my strategy and positioning in the market need to be, they need to be things that make logical sense with one another, not only because of how you position yourself in the marketplace, but because the capabilities that you need to render them need to be consistent with one another. Right? If you think about trying to be low cost and premium at the same time, it's near impossible to figure out how to configure your organization from a people perspective, right? From how you organize your processes, and from how you make your investments in capital, and then ultimately how you position yourself in the market. Just to say a little bit about the topic of bundles for a second. One of the things we believe is that the first wave of some differentiation that will start to occur is what will be around the idea of healthcare bundles. We're already seeing in the marketplace a number of employers be interested for a set of services, a fixed and well-defined price for a set of services that is agreed to upfront. Lowe's is doing this with Johns Hopkins. Walmart has programs in place with a number of institutions. So this sort of behavior we see is sort of the first step in health systems really starting to get clear about what their point of differentiations are, and then start marketing that differentiation in the market in a way that's very different than it's manifested itself today. And so just for a second, what's interesting is that if the bundles are well priced, people always ask, well, will consumers go there? Right? And we surveyed several thousand consumers here, and what's interesting in the data here that there are over half of consumers who will actually go to another hospital. Say we'll move from one to another if they found a lower cost bundle available to them. So what it says is there's pressure on the employer side, there's pressure from the consumer side as well. Talk a little bit about what this all means for operating models. So how then, if you are trying to position yourself in the market, how do you then want to organize yourself? And there's really 5 different kinds of operating models we see coming to bear. The first one is probably, I'd argue, the purview of the large national systems, the Catholic organizations that are forming across the US that are very large in nature. And they tend to be geographically dispersed, and they tend to take what are undervalued assets that would benefit from the expertise, if you will, of national or broader organization. And then those elements are put forward. So you might take revenue cycle, and you might consistently apply it across all of the facilities in your portfolio. You might take any clinical and process knowledge around evidence-based guidelines. You may take that and you may actually promulgate it across your entire system. Investments in EMRs, all of the back office types of services. So the scaled portfolio model, you see it here as an example, LifePoint. You could argue in many ways, HCA certainly is pursuing the scaled portfolio model, and then on the Catholic side, just as an example, Trinity. Right? Again, broad geography, really trying to bring the elements that have relevant national scale to bear. There's a second category that we've called geographic cluster, and this is about trying to build a presence in a set of assets and a model within what we call a contiguous market. So these tend to work well in dense market environments. This is where you can benefit from a combination of market power, not necessarily in the traditional sense of I can extract higher reimbursement, but more because I am relevant to the other elements of the delivery system in the market. So I have enough of mind share and volume with the providers, the physicians in my market, with the nursing home, the home care entities in a geographic area, that they are willing and interested to work together, right, around a variety of different value-based models and reimbursement schemes. And so just examples here, Advocate here in Illinois is a very good example of sort of where they're using what we've called a geographic cluster model, what Steward Healthcare is trying in Massachusetts, Fairview in Minnesota, just as some examples. These organizations, you'd argue, are probably most naturally suited to be able to take population, or their interest is really in population health management. They might be able to take, they might be more readily equipped to participate in accountable care organization-like constructs because of how they're configured. This third one we call hub and spoke, and it's exactly what it sounds like for anybody who flies on an airline and major carrier and has to go through Chicago or Atlanta. And this is the idea that we try to, that we have a central hub where all of the complex chronic types of conditions, so tertiary and quaternary care, are delivered. And we do all of the other less complex elements. We do most of the secondary care, primary care, distributed in the community where patients want, and we only feed the things to the center. So this is classically where you see a lot of academic medical centers thinking about this. We have Northwestern on here. Certainly University of Chicago, you could argue, has some variants of a hub and spoke model as well. The clinical innovator, I think we talked about it, but the main thing here about clinical innovation is really the point of differentiation in their model is all about monetizing intellectual property, right? So they by being innovative, by figuring out how to do something no one else has, and then trying to scale that. Look at Cleveland Clinic and what they've done, for example, with community health systems. It's really about, I take the innovation that I've developed, the intellectual property, and now the clinic had the opportunity through a partnership with a broader system to be able to leverage that intellectual property. And then finally, there is the model, the fully integrated model. And we're not seeing many folks go here, but you know, to everyone here, this is Kaiser Permanente. This says that I have all the delivery assets, but I also have the financing pieces of the equation as well. Last slide, just some data to show. This is research we've done around what happens when organizations merge. So we looked at all of the hospital and health system transactions where we could find publicly available data for a 10-year period from 98 to 2008. And there were something on the order of about 220 different hospitals that were involved in the data set. And what we found was, and we looked at their performance along a number of dimensions, but just shown here is operating margin. And what happened to the entity sort of pre and post. And what's interesting is that it's really uneven, right? So there's some that actually did better, right? So about half, 22% of them actually went from negative to positive. But interestingly, almost the same amount, 18% actually went from positive to negative. And in the aggregate, what we found is that when you measured it against the overall performance index, only 41% of those mergers actually outperformed the overall market. So it does not to say that mergers aren't necessary or important or potentially valuable, but it is to say that they should be done with a fair bit of caution and a real understanding of why it is that you're pursuing the M&A activity. And then just lastly, to that point, we found mergers that are done for the purposes of capability acquisition as opposed to simply we need to get larger. And one to say we need to learn and we need to build a certain capability. Those have tended to yield more success in our data set than the ones that were done for traditional reasons of simply size and scale, hoping to get more market power with a payer in the market. So with that, let me just stop, and I don't know where I am on time, but we're happy to take questions and if there are any from the audience. Great.
What would you say would be the most crucial aspect to question was, what's the most important thing to do to counteract the decline in revenue? Is that right? Did we get that right? Okay, so I think the easy answer is always it depends. I think it depends on where, kind of in what service line or in what unit you're going to be experiencing a decline in revenue. Because there's a set of services that you're providing that are highly differentiated, and they're the most important thing to counteract decline in revenue is to shore up that differentiation to make sure that your customers, whether it's commercial payers, government payers, individual consumers, employers in your community, really understand that differentiation, really understand that you're delivering superior value, superior outcomes, better experience, better access, so that you can continue commanding a premium for a set of differentiated services that you're providing. For a set of commodity services that you're providing, and sometimes it's a hard fact to face that a subset of services you're providing are commodity services, let's say diagnostics that a national diagnostics provider could offer as quickly, with higher fidelity and lower cost. There you have some tougher choices to make about whether you can continue providing those in a relatively higher cost setting of a hospital, or whether it no longer makes sense or only makes sense in a subset of cases where it's concurrent, let's say it was a medical procedure. So the first step is to understand how are you positioned, how are you priced compared to the market, then shore up the differentiation in the truly differentiated area through demonstrating value, and then take a hard look at the relatively more commodity type services to see down the road whether you'll be able to continue providing those or not. Does that make sense?
Just one more question to keep us on time.
I've heard mixed things about the impact of exchanges. Now starting to come up that insurers are not going to put exchanges in all states, well, the states. And if they don't have large networks in volume in the states, they're not able to impact that particular market. So some of the impact has been predicted about these exchanges may be low. Some thoughts?
Yeah, no, it's a great question. So the question basically is if I understand it correctly, is if exchanges don't necessarily get the traction, right, then perhaps some of the impact here would be blunted. So firstly, I think it is true that the greatest pressure, at least on the commercial reimbursement side, is coming directly from the exchange environment, right? So to the extent exchange adoption does not occur as rapidly, and we're actually quite conservative because we don't believe exchange adoption will happen as rapidly as I think some of our competitors believe the market will shift overnight. A couple of things I would say. First thing is that at least in the early years, a lot of the exchange adoption, interestingly enough, is coming, or a lot of the exchange volume will come from the subsidized market as opposed to from the upper ends of the commercial market. So yes, I think some of that will be blunted. It won't be as significant, but nonetheless, there's a lot of reason to believe that those individuals who are subsidized, when they see the amounts of subsidies, from California, I think for a family, subsidies are for families who are $90,000 are subsidy eligible. So you think about that. So there are a lot of people who are going to be subsidy eligible across the country. So to leave that on the table, I think as advertising and other things take hold and people start to understand that exchanges offer that, we may have pushed a problem a year or two into the future, if you will, but it's not to say that over time people won't understand, at least if you're up to 400% of federal poverty level, exchanges are a great way to be able to get an affordable health care or healthcare coverage. The second thing I'd say is that people forget, but if you look at the secular trends of employer-sponsored insurance, even before health reform even took hold, they've been doing nothing but declining, at least at the national level. There are certain markets where, interestingly, Massachusetts is going up, but everywhere else, it's by and large been going down. And what that says is the affordability piece of healthcare is driving people out of the commercial group market, and that's going to happen no matter what. So whether that pressure comes directly because of what's happening with exchanges, or because that pressure is coming simply because it's unaffordable, there's going to be that level of pricing pressure that limits the ability of commercial payers to cross-subsidize for the government business in the way that heretofore they've done for many health systems across the country. With that, I just wanted to thank everyone for their time and happy to stay.